two comments. Number one, prisons cannot use controlled substances unless the patient's in a confined setting, like in prison hospital. They have like little hospitals in the prison, but there are no controlled substances allowed out on the wards, out on the different places where they are. So cannabis is a controlled substance. Nothing is allowed in prisons. Second thing about smoking, when I tell patients, if they want to smoke, I'm not the police. Combustion occurs at 450 degrees. Vaporization occurs at 200 degrees. At 450 degrees, you will destroy 20% of all the cannabinoids you just paid for. So if you want to destroy 1/5 of your product, that's fine. But that's what happens when you burn cannabis.
So why would they want to?
Why would they want to? Because it's the old way of doing it. Sorry?
I had been to a lecture, I don't know, 6 months ago, and the guy talked about some of the concerns about respiratory issues. And so I had actually taken the step over the last 6 months, and I no longer authorize any inhaled versions. Pissed a couple of patients off, but no one's like fired me over it. But I don't know. If you could comment on that, I'd really.
Well, questions about inhaling cannabis products. So first of all,
about lung.
okay, yeah.
Lung
Inhaling anything that's burning is bad for your lungs. I don't care if you're standing next to a forest fire, or if you're smoking cigarettes, cigars, pipes, tobacco. All inhaled burned products are bad for your lungs, period. End of sentence, includes cannabis. Vaping cannabis cartridges that have been properly prepared has never resulted in a known lung problem. The famous E Valley epidemic we had a few years ago in Utah was from false cartridges which used a vitamin E acetate oil in the false cartridge. That's what was causing the disease. I actually asked one of the processors, why would they use vitamin E oil in the cartridge? He says, you have to pass the bubble test. Bubble test? Says the people who use it are smart. They'll take a cartridge that they use for vaping, and it'll have a little bit of air in it. They'll turn the cartridge upside down and watch how fast the bubble rises. It turns out that vitamin E acetate oil, the bubble rises at about the same speed as real good cannabis oil. And that's why that was popular. But they've been using good products for now probably 30 years, starting in places like Connecticut, Colorado, where they've had good, honest, processed, safe cannabis oil vaporization products with no evidence of lung disease. So I'm not a pulmonologist, but the literature I've looked at, I can find nothing that says vaping cannabis causes lung disease.
So you're almost as comfortable with them using that as any other,
Well, we'll talk. Hopefully we'll talk about how to decide what to use. There's many different ways to take cannabis. We'll talk about that. Now, we're not talking about somebody with emphysema, asthma. That's different. And those people can react to a lot of products. I don't recommend vaping for those people. But anyway, so this could be my swan song for presenting, because I'm actually just about ready to totally finish clinical practice. So it's probably not appropriate for me to come back in the future when I don't have any patients of my own to talk about and things like that. But that's who I am. The reason I put on former deputy director is when this law was first passed, I was a deputy director of the health department, and my boss said, Mark, you're in charge of getting this law implemented. So first of all, I got Rich Ogden, who's really smart, good administrator, to help us get together a team. But I got to spend 1.5 years studying medical cannabis, so we could decide how to look at it, help write the laws and things like that. So I got to learn a lot about it. I will tell you honestly that I was opposed to the initiative that was on the ballot, mainly because it had grow your own options in there. And as we talk about, cannabis is very dangerous for people who are pregnant, because of infants, and for children. Cannabis causes neurodevelopment disabilities. So it's a really bad thing, And actually, the technical people say it's bad for your brain up to age 25. Utah decided age 21 would be the law we'd make for having to get special permission. Anyway, that's why I have the deputy director thing on there. Let's see if I make this button work here. Okay, just for fun, cannabis is a flowering plant. Comes in 3 different varieties. Sativa was the one that was famous for supposedly high THC content, and indica was the one supposedly high CBD content. Ruderalis we don't grow. Hemp is actually a variety of sativa, although it's very low in THC. I've had patients come in and say, well, I want to get that sativa stuff. I explained to them that you don't ask for that anymore. That's so old-fashioned to talk about that, because all these growers have all these varieties, and by controlling the temperature, the light, the humidity, the water, the fertilizer, they can change the content of these plants to grow whatever they want to produce. So asking for a variety doesn't mean anything anymore. And most of what they're growing are the sativa varieties, because they can get the more THC out of them. But those names are old-fashioned, again, to do it. Little history, you probably know about this. It's an old stuff, been around a long time. Turns out the seeds are really useful. Some people who grow hemp like to gather the seeds from the hemp plants because they're really good for food. I love the recreational part. One of the books I read about cannabis when I was studying this was written by they're basically anthropological botanists. What an odd combination. They had two theories of how human beings discovered that cannabis could be psychoactive. Theory number one, when people were gathering the seeds of the plants, they'd get all the sticky stuff on their fingers. The rosin is where all the good stuff is. And then when they were licking their fingers, they got really high. That was one theory. Second theory was they used cannabis plants like hemp for fiber. After pounding the fiber out of the plants, they put them in a big pile, and they started burning the fire, big bonfire, and then the wind changed, and it blew back at all the people. They got real happy all of a sudden, and that was the other theory of why they discovered cannabis psychoactive effects. But whatever you want, that's fine. I want to talk about the physiology, pathology, and pharmacology, and I'm going to talk fast. You can raise your hand and stop me, but I want to leave time for questions also. Again, we're not prescribing cannabis. We do not prescribe cannabis. We're just recommending. So you want to know what are the indications, what about dosing, how about some toxicity and monitoring. The biggest concern I have in being involved in this is people do not talk about the dangers of medical cannabis, the drug interactions of medical cannabis, and there are significant ones that you have to know about. And that's the thing that worries me about the LMP program. So LMPs are not required of any training, all right? Now some of you, I'm glad you're here. You maybe decided to be an LMP, but at least you got some training. If you don't understand some of the dangerous reactions, you could have a problem, and we'll talk about that. So, important. So, I'm sorry? You're not writing a script. You are not writing a script.
Okay, but, adolescence is really the very vulnerable time for people in their brain growth and so on.
That's why Utah law says an adolescent cannot have medical cannabis unless it goes through the compassionate use board. If I have a teenager comes to me and the parents want them to be on medical cannabis for some reason, and if I happen to agree with them, I got to fill out a petition form with them, has to go to this board of 7 physicians, they have to review it, discuss it, ask for more information, and only if they feel the dangers of not using cannabis outweigh the dangers of using cannabis. Now, I'll give you an example of one case like that. Severely autistic child who has violent outbursts, tears up the furniture, kills the dog, beats up the siblings. They want to settle a child down with some cannabis. Well, this child's severely autistic, already developmentally disabled. The fact is the harm that cannabis will do to that child is much less than the benefit it'll give the family if they can calm them down a little bit. So that's an example of where they had approved a child to be on medical cannabis. But there's a concern with that. It's a balance. This is new stuff, and this was always strikes me was, I'm an old guy. I finished medical school in 1972. We didn't know about this. I mean, how many of you were taught about medical cannabis in your medical schools? How many of you ever heard about the endocannabinoid system in medical school? A couple younger one. Wait a minute, you heard about it in medical school? Jenny, you're almost as old as me. So it's all new stuff, which makes it a little bit challenging. But some interesting in that. And what's interesting about the discovery, human beings actually produce 2 chemicals that are very much like THC. We produce 2 chemicals that are very much like CBD, and they are working in our endocannabinoid system to maintain balance, much like we do with our parasympathetic and sympathetic system and so on. We're working along with all the rest of our body parts to maintain certain balance in our body. So we already have those things. The system, I'll let you read that, but it's actually, you can find receptors for the endocannabinoid system in all kinds of parts of our body, and they relate to all kinds of things: appetite, digestion, mood, coordination, and on and on and on. And still lots to learn about that. More things to find out about where they work and how they work, what they do, including what the side effects would be about it. The 2 chemicals that are most common talked about, there's a chemical anandamide. That's the one that we make in ourselves. It's very much like THC. This actually was first discovered when they found a patient who was almost insensitive to pain. And in doing evaluation on this patient, they found this patient had a genetic defect where they could not break down anandamide in their system. They had very high levels of anandamide in their body, and they weren't feeling pain. That was one of the first thoughts for this to help explain that. And there's stuff called 2-AG is one of the other 2 chemicals that acts like CBD in our body. And again, where you find these receptors. Again, CB2 receptors, I mentioned CB1. I'm going to go through these quickly. That's about the patient who had the high levels of anandamide, didn't have pain. Also showed that if you had patients who you made them have neuropathy, you could increase their CB2 expression, which was interesting. And people often know, especially if they were using it as cultural or as a just popular thing, that marijuana does heighten sensory perception, touch, smell, sight, taste, and hearing, and so on. But for some people, that's not a desirable effect of cannabis. That may be a side effect they don't want. CB1 and CB2, for CBD we're talking about, CBD. CBD is an antagonist. THC is an agonist. So CB1, CB2, CBD is an antagonist at those receptors. Does not involve binding. It actually increases the availability of our endocannabinoids. And as you know, that the FDA released approval for a CBD product for seizure control, right? Epidiolex is CBD. And they did say they want people to monitor things like serum transaminase and bilirubin levels in patients, if that may be an issue for them in terms of liver function. I've never seen a problem with patients doing that, but that's something that the FDA says about people on CBD. CBD is important to know that it's very lipophilic. So if your people are taking lots of fatty food in their diet and they're eating CBD, they can have a really marked increase in absorption of CBD, so it's important to be aware of that. And likewise, topical CBD is doesn't work very well. And you have to put it in a vehicle that'll penetrate, because as you know, our skin is more hydrophilic, not lipophilic. So CBD preparations for the skin often have very high amounts of CBD, and they're often in more of a water-based formula to help it penetrate to be better. CBD has no psychoactive effects, none, which is nice. And some patients find that they can just use CBD and they do very well without any psychoactive side effects. Experimentally, so in this case rats, it does decrease inflammation. A lot of the people who are big proponents of CBD think it's great for curing all kinds of inflammatory diseases. The evidence isn't really clear whether it really does that or not, but theoretically that should be a benefit. THC is an agonist at these receptors, CB1 and CB2 receptors. THC causes the psychoactive effects that people can get. Some people want it or don't want it. THC will decrease nausea and vomiting. Classically, the studies were done based on chemotherapy, but again, talked about cancer and the value for that. They noticed that it improved appetite in patients, particularly in HIV patients, and then known to reduce pain, especially neuropathic pain. And this is a wonderful thing. And this is where I was, I guess, most amazed in my own practice with doing this, is where I had one gentleman with a traumatic neuropathy and a lady with severe diabetic neuropathy, just severe pain. The lady and both the man, they could hardly walk. They had so much pain in their feet and legs, they almost couldn't bear to be on them. Put them on THC, and the pain was pretty much gone. They're walking, they're wearing shoes, they're active again. Now, the key we'll talk about this more later, but when you give somebody THC and you don't want this kind of effect, you have to balance it with CBD, at least equal amounts, 50-50, if not higher percent of CBD. But that will block, CBD has the ability to block the psychoactive effects of THC. Makes a huge difference for people when they're going to use cannabis. Well, you could, but that's why it's important in the pharmacies. The pharmacy is supposed to label them. Now, I was talking to Rich about this. My patient's report is not 100% following the law. The law says that all the products must be labeled with the milligrams of THC and milligrams of CBD. That's the minimum. And as Rich was saying, some of them will do more if you ask for analysis. Not all the products do that. But that's what, and I tell patients, you need to go to the pharmacy and you want to tell them you need at least a 50-50. I'd actually recommend you do a 60-40 or 70-30 mixture to start out with, higher CBD, because you don't want the fuzzy brain effects that's going to make it hard to drive and hard to take care of your kids and things like that. But we want the benefit of the THC without the side effects. But it was really good. Same thing with muscle spasticity. THC is the major ingredient that affects muscle spasticity, like in MS patients and again, cerebral palsy patients. But again, with the CBD, we minimize the brain stuff. Jenny?
So on the milligrams that are listed on the packages, say, of the gummies, I don't see them listing a one-to-one on CBD THC. I mean, it tends to be way higher on THC than CBD, like the dragonfly,
The pharmacies make a lot of money by selling high THC products. So you're right. You may, and that's why we'll get to this in a minute. I don't make a recommendation about a specific product for a patient, because when they go to the pharmacy, they won't have it. I'll say, I'm giving this patient a 50-50 cube. I don't have them. Now what do I do? So I tell the patient, you need to have a balance. If the pharmacy doesn't have a balanced product, then you're going to have to buy more CBD or get more, which you can buy at any store to get CBD, and you're going to have to make it balanced, if not a higher percent of CBD. But you're right. They make their money with the high THC products. Yeah.
I've seen products now with a higher
There are at least, last count I saw was at least 122 distinct cannabinoids in these plants. The two most active by far are THC, delta 9 or delta 8. Delta 8 becomes delta 9, and then the CBD. But all these other ones are being studied, but they're very small amounts. But some patients think that that makes a difference, and there may be some truth in that. So some people will say, I'd like a product that has CBG or other. Yeah. The CBG is not going to block the psychoactive effects. It's the CBD that will block the psychoactive effects. So they want CBG because if they feel a benefit, that's fine, but that's not going to stop them getting a fuzzy brain if they have a lot of THC. Yeah. Okay, here's some, but I think the critical stuff. Now, I'm by far no expert on the cytochrome system. That also wasn't invented when I was in medical school. We'd have to memorize all these fancy letters and numbers. But as you know, we now know a lot about how drugs are metabolized by the liver. And we know that when certain enzymes are impacted, they may either speed up the breakdown of a product or they may delay the breakdown of a product. And this becomes really important. And it shows how, this little slide mentions how, where THC and CBD are metabolized. So again, I'm not so good about memorizing all the CYP numbers, but this is what it means to me is this. THC and CBD, by inhibiting this enzyme, increase the availability of some of the SSRIs, particularly Zoloft and Paxil. If I have a patient on Zoloft and they want to try cannabis, if they're on a low dose, like 50 milligrams a day, I'll probably say, just be aware if you have any side effects. It might be like feeling hyperactive or things, sort of the serotonin syndrome things. Rarely a problem. If you have a patient who's got severe depression and has been put on like 200 milligrams a day of Zoloft, for example, I'd be really cautious about putting them on cannabinoids. I would start really slow, and I'd probably ask them to try to decrease their Zoloft when they started doing that, because there's going to be an increase in the concentration of their SSRI. THC, CBD inhibit the enzyme that affects the breakdown of warfarin. If you have a patient on Coumadin, and also you see the next one, the direct oral anticoagulants, any of those anticoagulants, if you have a patient on that, if you give them cannabis, their anticoagulant effect is going to go up significantly. You have a patient on warfarin, give them cannabis, they may have a massive hemorrhage the next day. So you have to warn people about that. And if you're going to do that again, you have to lower the doses of both ingredients so you monitor and see how they're doing. These are to me, the biggest dangers about people not understanding cannabis, where something bad can happen. I just read recently that cannabis also has been shown to decrease the effectiveness of Plavix. So if somebody who had a stent and now is on Plavix, and it's been shown to decrease the effectiveness of digoxin. We don't see a lot of that anymore, but if somebody's on digoxin for their heart, cannabis will decrease the effectiveness of those two drugs. So something also to be aware of if you're recommending cannabis. Rich touched on these already, but I'll just go through these again. There actually was a study done by the National Academy of Sciences a few years ago that actually said what they learned about cannabis. So for chronic pain, especially neuropathic pain, really good evidence actually that's effectiveness. For nausea and vomiting induced by chemotherapy, good evidence of that. You all know there was a synthetic THC marketed, right, for nausea and vomiting. Never went over really well, didn't do the best, Marinol it was called. Dr. Machulam in Israel, who learned about all this, studied that, he said, the reason Marinol doesn't work, number one, it's synthetic, and number two, it doesn't have any other cannabinoids with it. It doesn't have the benefit of the whole team. Dr. Machulam coined a word. He called it the entourage effect. Some patients do not do well with pure THC or pure CBD. They need the other cannabinoids. They may need the terpenes that are also with that. They may need the whole product. Those patients like to have flower, for example, to use that because it has the whole team, this entourage effect they call it. But that was where the nausea vomit really helped. Spasticity, good evidence that it helps with spasticity. Good evidence with Lennox-Gastaut and Dravet syndrome, and then recently they added the tubercular sclerosis. So even Epidiolex now that has 3 indications. So the prescription CBD you can buy is actually indicated for those 3 things. Moderate evidence for sleep disturbance because CBD is a little bit sedating. So people can take high doses of CBD and it may help them relax a little bit. And that's fine because CBD is not, doesn't have any psychoactive problems, so I never worry about that so much. THC is not, it can be a depressant, CNS depressant, but at times it hyper up your senses. It's not good for people who have insomnia, so I don't like to do that. And then evidence was pretty poor for people trying to just gain weight or just stimulate their appetite, even PTSD, some pretty poor evidence. Anxiety, that's why these aren't on the list until the legislature decides to interfere with that and decide what they want to do. And then no evidence for cancer. Now this study was more about actually helping to kill cancer cells. What's interesting is if you put cannabinoids in a petri dish with cancer cells and normal cells, the cancerous cells will die. They'll go through apoptosis, and the normal cells will not. Now, what does that mean? in life, I have no idea, real life, but it's interesting to be studied. So I think there's more work to be done. So maybe at some point in the future, there'll be a role for medical cannabis relating to treating cancer, but not now. Originally, they didn't have evidence for epilepsy till the Epidiolex people had to go through the whole clinical phase 3 trials to prove it. Interesting that Lou Gehrig's disease and Huntington and Parkinson's, where there is a lot of spasticity, they didn't find good evidence for that, even though we find that for a lot of patients it does help, but this big national study didn't find good evidence for that. People think that irritable bowel, because it's an inflammatory condition, that CBD should help it. Yeah, not really good evidence. In fact, if you have a patient who has irritable bowel problems and they come to you and they're having a lot of diarrhea and cramps, ask them if they're taking CBD. That's the one side effect of high dose of CBD is diarrhea and cramps. So that may be a problem for them. Somebody mentioned about opioid addiction. I just want to mention this briefly. We should talk about that. I've probably seen 3 or 4 good studies now. Generally, the relationship of opioids and cannabis to treating pain. What they find is about a third of the patients who have chronic pain can do fine with just cannabis. And I have several patients who have done that. They don't want opioids and they just do cannabis. They're doing fine. About a third of the patients say, I don't like that cannabis stuff at all, and I want to stay with my opioids. It work fine, don't bother me. And then a third of the patients want both of them. They say, I need the combination. It works really good for me, the combination. So that seems to be proven over and over and over. So can you use cannabis to treat opioid addiction? No, it is not approved for opioid addiction. It will probably not be an effective approach to do that. If I had a patient with chronic pain and they want to try cannabis as an option, I encourage them to do that. But I actually tell them the truth. I say, look, you got about a 1 out of 3 chance that you'll drop your opioids. That's what I think. I'd love it if you do, because this can be very effective with less side effects. But the research shows that a third of you guys will stay with opioids, another third will use both, and maybe 1/3 will go just cannabis alone. But my biggest success has been patients who've come to me and said, Doc, I just don't want those opioids. I hear about all the bad things and the overdose and the deaths. Can I try cannabis? I said, that'd be great. And then they come back and say, doing well. That's a success story for me. Real important, contraindications. We talked about children. Again, we're back to that here with pregnancy. Cannabis causes serious neurodevelopmental defects. It will damage babies' brains seriously. It will damage children's brains seriously. It'll damage teenage brains seriously. Cannabis was shown to cause schizophrenia in teenagers. So it's a dangerous drug for people who are young. And again, the purists say that's anybody under 25, but the state law says anybody under 21. So just interesting that. People with heart disease have to be careful about THC because THC can often drop your blood pressure and cause your heart to race. And those two combinations, if you have coronary artery disease, that's a great way to cause angina or heart attack. So it's a bad combination for that.
Question.
Yeah.
Doesn't it also raise your epinephrine level?
This kind of epinephrine level.
One of the short phases as it goes through.
Yeah, I haven't actually seen that. I really can't answer your question. I honestly don't know the answer to that. Yeah, I don't know the answer. Now, theoretically, if you are having hypotension, your epinephrine level should go up, right? Your sympathetic system should try to compensate for that. But they point out is with cannabis, at least that period of time when you first use THC, when the blood pressure may drop and you get rapid heart, that's the time when they worry about people having adverse heart effects. So that's a good question. And then we already talked about not using it if you're under 21. And then the issue about smoking and vaping, again, not with lung disease, but otherwise, if it's truly a purified cannabis oil product for vaping, I don't have a problem with that. Smoking, I have a problem with that for any kind of smoking. And also, I tell people, you're going to waste 20% of your money. This is expensive stuff. If you go buy the flower and you smoke it, you're just wasting 20% of it. You're burning it up in the smoke. You're not going to get any benefit from it.
Sorry, I'm surprised it doesn't have they haven't had any lung damage or bronchial damage because it's irritating. A lot of people will cough when they vape.
There are people who get irritation from all kinds of things, right? They get irritation from their inhalers of different kinds. Like, what's the one inhaler with the powder, right? I have a lot of people can't use that powder inhaler.
I can tell you that's pretty, that's not very common, but
Yeah.
they're as common as
Well, so irritation is one thing, but significant lung disease, damage, and scarring. So if you go back to the states that have had vaping of cannabis for like 30 years now, no evidence of chronic lung disease. So no evidence of progressing on to like emphysema or making them asthmatic. So it seems, now sometimes take more than 30 years for something, but it seems like purified cannabis oil does not have a problem. If the purified stuff. Yeah.
Is there more psychoactive Babitz read initially? Is that why they want to use it that way?
Well, okay, so let me talk about actually dosing right now. If I have a patient who's never used cannabis before, not sure how to do what to do, one of the things I'll say to them, look, you have a couple of choices. What I'm going to encourage you to do is use a technique that gives you rapid onset, short duration, so that if you don't like it, it won't last very long. And if you like it, you'll know that it works. And also, you start with a low amount, and if you need to increase it, you'll figure out what your dose is. The two rapid administration ways are vaping, onset within seconds, but only lasts 1 to 2 hours. The second rapid way is actually the drops under the tongue. They actually come on a little bit, take a little longer, maybe a minute or so, maybe last 2 or 3 hours. But both those techniques will allow somebody to have fairly rapid onset, and they know if it's going to work for them. And if they need to do a little second dose, they can without a problem to do that. Now, once you do that and you figure out it's working, then what I say, look, again, 70% of my patients are chronic pain, just like the statistics. If we're dealing with chronic pain, you have pain 24/7, basically, and they all say they have a hard time sleeping. So I say, look, okay, you get a vape pen, for example, okay, and it has 2 milligrams of THC plus 4 milligrams of CBD. And you can vape 1 puff of that to get that dose, and that works for you, and it works for about 2 hours. So you have to do that 12 times a day to get the effect. Well, 12 times 2 milligrams is 24 milligrams plus 40 milligrams of CBD. Now I want you to go to the pharmacy and I want you to buy a gummy, something that you eat, that's a third of that dose. So an 8 milligram gummy with 12 milligrams of CBD, because the oral cannabis will last 8 hours. Takes 2 hours to start working, so be patient for that first dose. Don't take a second dose, just be patient with the first dose. But once it starts working, they can get 24/7 relief by doing it. So I use oral or vaping mostly, for me, only to figure out what your total dose should be, and then I try to convert to an oral dose. Now, Rich will have to cover his ears. The state law implies that the flower is for vaping. That's not actually accurate. Flour is great for eating. You can have somebody grind up. If I have a flour, and the flour might have 30 milligrams of THC, well, all I want is like 3 milligrams. So I got to get the patient to grind it up and divide it into 10 little piles. So it's not easy. It's a little complicated process. But each little pile now is 3 milligrams of THC, and they can put them in little plastic baggies. They can sprinkle that ground up flour on a piece of toast. They can put it in their soup. They can put it in their tea. They can just eat it with some peanut butter or jelly, whatever. And they'll get the same benefit of that gummy, and probably a little less expensive overall if they get willing to grind up the flour and separate it and all that kind of thing. So flour can be eaten also, and has the same benefit of eating a gummy. So it can be done that way, and I'll tell patients about doing that, but definitely not smoking it, but eating it is an option. Because vaporizing flour, you have to have a device to vaporize it, and that can be complicated. So, okay, so I think we kind of covered this a little bit already, but anytime a patient is going to see you, and well, I'm a family physician. I don't see patients for medical cannabis. I see patients for medical problems. It could be pain. It could be nausea. It could be heart disease. It could be lung disease. It could be broken bones. For some of those conditions, cannabis is a beneficial treatment. And for other conditions, it has absolutely no role at all. And that's like every other drug that you use. That's our job, right? Make a diagnosis and look at the treatment options and then recommend what you think is best for the patient. So some patients, I wouldn't recommend cannabis for anybody. Other patients, I'll say, I think this would be a good option for you. And by the way, in my clinic, all our billings were done with insurance or Medicaid, and they all were for a medical problem. They weren't for medical cannabis, they were for a medical problem. Nobody comes to my clinic and says, I just want a medical cannabis card. You come to my clinic for a medical problem, I'm glad to see you. Don't come to my clinic and say, I just want a card. No, I don't do that. Because we're going to bill your insurance for healthcare problems. When they come in, we're doing a good history and physical exam. We're really looking at the controlled substances stuff. What other controlled drugs are they using? I'm going to check the controlled substance database, which is required anyway. I'm going to talk about different treatments, what they're doing. I'm going to go through a whole lot of education about cannabis, like the drug interactions, like how to take the cannabis in different dosing formats, what works. How to start with a lower dose, like low amounts of THC at a time, so they don't get the side effects, about using CBD to block the side effects. I'm going to write up a full note of that, and that note I'm going to send into the state. My initial visit, that note's going to go to the state as a part of the EVS for the first visit, because it'll help the pharmacist with understanding why the patient's there. I do not tell the pharmacist what the patient should take, because half the time the pharmacy doesn't have what I tell the patient to take. So I've given up on that. I've told the patient things like make sure you have a balanced product or more CBD, or I want you to do something that's rapid onset like drops or vape. I'll go that far. But other than that, I say you talk to the pharmacist, figure out what do they have, what'll work for you, you try something. And I really give patients a lot of credit. My patients have been very good about trying what different works and finding out what's best for them. You know, they don't need me to tell them you must do this or that. So it's actually worked out well for me. And I've been very impressed by the pharmacists who are hired by these cannabis pharmacies. Very knowledgeable about being a pharmacist in general, other drugs, and very knowledgeable about cannabis. So that's been a good thing. So, and then if the patient's doing really well, they don't have to come back for their renewal. Although I guess the law is once a year it's face-to-face now, right? Is when?
Just the initial visit is based
Oh, just initial?
when it's still required, but it can be done via telehealth.
Okay, so telehealth, so do that. Because I really don't like people have to pay and travel for a whole, if they're doing fine. So they'll do a telehealth or a phone call or whatever to do that. And then if there's other patients, if the patient has other providers where this might be important, just like if you put somebody on a drug, you may have to tell their cardiologist about it or whatever. Same thing here would apply. So I'm a qualified recommender, so that's fine. For people, for the most part, it's start low and go slow with increasing dosing. Start low, go slow. Especially for people of my IRC, which is elderly. You want to do that. As I put down at the bottom there, typical amounts of THC, 2 to 10 milligrams every 8 hours. Typical amounts of CBD, 2.5 to 10. Again, that's per kilogram, milligrams per kilogram. That can be, CBD will tend to last a little longer. You can do it twice a day, but most times you take the mixture, so it's usually 3 times a day. A little hint for your patients, if they're using much more than 30 milligrams a day, they're not using it for medical reasons. There's been good studies that pain control kind of maximized at about 30 milligrams, spasticity maxed out 30 milligrams, nausea maximized about 30 milligrams. You get people using 50, 60, 100 milligrams a day, that the maximum the state allows. It's not for pain. So that patient and I will be having a discussion about that. They can purchase a ton. This is where the law is. Well, let me put it this way. The law was made up by legislators. What else can I say? Did they ask me about it? No, they didn't. So they're saying somebody can have 20 grams of THC, and I'm saying 30 milligrams a day. That's less than a gram. They can have 20 grams. There is no logic. So thank goodness the pharmacy can have some control. Well, they only will dispense, once they figure out what the patient's going to take, they can only dispense a 28-day supply. So once they figure out the patient's dose, they can't, well, I want the 30, no, you can't get the 20, you can't get the 114 grams of flour and you can't get the 20 grams of THC just because you want it. It's going to be based on what we decide is your daily dose. So that's a good thing about it. There are some parameters there. But think of those numbers as something helpful. And again, emphasize, other than sort of GI effects, CBD overdose, not really, and bad effects, not really. So I don't worry about that too much for people. And in fact, you don't have to go to a cannabis pharmacy to get CBDs, which is also a good thing. Go over this again. We talked about just briefly a minute ago. Inhalation is rapid onset. Sublingual, a little bit slower, but it's a good way to start things on. Oral edible ones, that's the one that's longer. You've got to be careful with that. Topical, highly variable, value highly variable. Suppositories is allowable format by the state, although I've never had a patient tell me they have suppositories in the pharmacy. I've never recommended a suppository, but that would be actually one that'd be like a drop. It'd be one, rectal mucosal absorption would be pretty fast, so it'd be work like that if somebody wanted to do it, but nobody's asked for that yet. Obviously, when I talk to patients, I really want to know how they're doing. Is this helping you or not? Are you having any side effects? What kind? Tell me what your dose is doing. Are you having any side effects, the psychological ones? Are you feeling fuzzed out a little bit? Are you having trouble with coordination? Are you feeling like you shouldn't be driving if you took it? Or things settling down, you got enough CBD that you're doing okay? I'll advise my patients when they first start taking cannabis, they've never used it before. So I want you to start taking it on a day when you have no really responsibilities. You're going to be at home, and you're not taking care of the kids, and you don't have to drive to work, and you're not going to be trying to fix the engine on your car or whatever. Because I want you to see how it's going to affect you. I want to see if you have enough CBD to affect the psychological things. Don't plan on doing a lot of things when you first start doing this because you don't know how it's going to affect you. But once you've taken it for a while, and that's like any drug that we prescribe, people will know how they're feeling. They can drive, they can take care of their children fine, they can go to the store and shop. Once they know how it works and how it's doing, they do fine. They're very functional. So it actually makes them, these 2 patients with the neuropathy, man, they're incredibly functional where they weren't before, which is an amazing thing to me. Very careful about the drug-drug interactions we talked about. I don't know if anybody has any patients on clobazam. It's an unusual seizure medicine for kids. but it's also another drug interaction with cannabis. I don't put it on the slide because it's not commonly used. The FDA talks about measuring LFTs in anybody on cannabis. I have not done that unless there were symptomatology that suggests it. I think it's just extra money to spend on people. Be careful about a lot of people with vomiting. Remember, some people think cannabis is good for vomiting. Cannabis causes vomiting. It's a hyperemesis syndrome, they call it. And so if you have people with vomiting, sometimes what they have to do is stop the cannabis as opposed to taking more cannabis. And it'd be safer to have them try stopping it for a while than trying to increase it. And then absolutely, I'm just adamant about not vaping any unregulated product that hasn't been approved and gone through these testing labs to assure that it's safe and pure because of all the problems we've had with it. CB said, I'm sorry, yeah.
Sorry, have you seen the hyperemesis problems? You're the first person I've ever heard say the 30 milligram dose ceiling. That's really going to revolutionize things for me. I think most of my patients, they get there and the pharmacist kind of says, okay, welcome to the candy shop. And they get whatever they want and they try these different things. I've had several patients have good effect, but then they seem to hit a plateau and then they don't like it anymore. I'm really wondering now all of a sudden if they're hitting some toxicity.
They're using too much. They're overdosing. They're building up a tolerance.
So do you put that kind of a ceiling on them, or do you still tell them, let the pharmacist guide you?
I say let the pharmacist guide you. I tell them that I want you to start with a really low dose, like 2 milligrams of THC per dose, whatever you're going to do. And when they come back and I'm talking to them, I'll just ask, well, tell me how much you're taking, what you're using. And I can always go on to the EVS and look at and see what they're actually being dispensed if I want to see what they're taking. I've had a problem with that, but it's a nice guideline to know because, frankly, the candy shop, a lot of patients, not a lot, there are a certain percent of patients who are using medical cannabis as a way to be recreational cannabis, just to get high.
Well, I mean, I'm thinking of one, 55-year-old mom who it really, really helped her headaches, but then after a while, she just didn't like how she felt, and so she quit it. I mean, but it was the only thing we found that really transformed her headache.
Did she have high CBD? Did she have enough CBD with it?
To go back and see if maybe she was getting 3 grams of THC instead of 30 milligrams.
And you have to have that balance. So, people, I always say at a minimum, when you start, you should get at least 50-50 CBD THC. But there's nothing wrong with having 70 CBD, 30 THC. Nothing wrong with that because the excess CBD won't hurt you in any way, but it'll sure block the psychological effects, the adverse psychological effects of THC. And that's real important for patients' satisfaction about how they're doing. And again, these 2 patients that I had, the guy with the traumatic neuropathy, the lady with diabetic neuropathy, they were both in their 60s, late 60s, and they both were very concerned about psychological effects and didn't want to get high and didn't want to be, feeling fuzzy or whatever. And so I told them, this is the key. You got to push the CBD to make sure you don't have that. And they've done really well. So that's what I would be thinking about your patient. CBD, again, a lot of GI things with diarrhea, decreased appetite, weight change, increased liver enzymes, at least theoretically. It's a sedative, so you can get too tired with CBD. THC also is a depressant because when people get tired, they can have too much weight gain in some cases, and then the undesired psychological effects are important. And then some people, if they don't have the CBD, they'll have those things like time and space and noises and sensory are just too high. The reason that the young kids abuse it, but that's not what most people want to have with it. General rules about safety things, especially when you're first trying it, at least 4 hours after inhalation, 6 hours for oral, and so on and so on. Those rules are real important early on, but just like any other drug, patients can get used to the drug, get used to whatever side effects. They're not having them anymore, and they're perfectly safe to drive and so on. The rules about driving in cannabis in Utah are pretty straightforward, which you can't be pulled over unless you're driving erratically. It's, that's why you would get pulled over. If you're pulled over for driving erratically and you have substances in your system, whether a higher amount of alcohol or opioids or cannabis, now you can be given a ticket for a DUI. But because you're driving along and you're not driving erratically, somebody can't pull you over and say, let me see if you have cannabis. Oh, I'm going to give you a ticket for having cannabis. No, you can't do that. And like Richard said, if you have illegal cannabis with the proper labeling and all that, just like if you have a legal prescription for an opioid, you're allowed to have that, and you don't get a ticket because you have that with you in the car just because you're driving. So if you're driving erratically, that's a problem for anybody.
Decides you're driving erratically, I don't think you can rely on that.
Well, yeah, I understand.
Pull you over, they're going to pull you over.
I understand that Ogden is a point system now for that, so it's probably more erratically driving up here, huh? I don't know. And then it's interesting, is aviation, you can't have it for 28 days. There's a lot of rules for pilots, but what they can and can't have and do that. This was interesting too, and I think it speaks well to Utah's program. When they were looking at all these different companies, the variability of what was actually in the product was frightening. And so it's actually nice Utah's, controlled. The CBD side of the product is controlled, the THC side of the product is controlled. And so I think when you look at the labels for the products that are sold in Utah, you can be very confident with what the patient's actually getting. So that's a nice thing about our program compared to other programs. So I think Rich and his team learned a lot by checking out other states and helping develop rules and things in Utah that make things better. Mm-hmm.
So if you have a patient that just wants the CBD, can you recommend that and not get any THC?
Yeah, and as you know, CBD is sold at many stores. You don't have to go to a cannabis pharmacy because it's legal to be sold over-the-counter drugstores, Maverick stores. I mean, there's CBD shops, and that's fine. So I would tell them, go to one of those stores, a lot cheaper. If you were to go to a pharmacy to buy it,
The concern then is just what you said, that the CBD may not really be what you think it is.
well, I think, now I better ask Rich, isn't all CBD in Utah has to be approved by Utah, yes or no?
So there's a double standard. When you take a look at the medical cannabis program, the products that go through that pipeline are tested more vigorously. There's a higher standard for testing because it's a medical program. But there are some companies that sell CBD and do it under what we call the hemp program that do a rigorous testing on their own. And
But aren't they have to be a Utah product, right? Isn't CBD still a controlled, it's a Utah product?
have to register with the state of Utah, and there's some testing that is done of those products, but it's not as rigorous
Okay.
as the ones that are in the medical program.
So how would you find out which those are if you're trying to get them?
You could contact the Utah Department of Agriculture and Food. They register the hemp products, and they could probably point you in the right direction for some websites that are legitimate, that have some lists of those companies. Yeah.
Thanks.
Bountiful, they come down, these pharmacies all have kind of high quality stuff. It's a little more expensive than what you buy at Smith's or at the vape shop. But
Right.
Got a question?
I found when I went to the store in Ogden, that the THC, they combined their THC with the CMB, and I asked them, I had psychological effects from it, so I said, I want 100% CBD. They said, we don't use it that way. And so they recommended a legitimate store that sold only CBD 100%. That was Roxy's out in Syracuse. So I know I'm getting good 100% CBD because the state has advised me to go there.
So interesting comment in two levels. Number one, the pharmacy you went to didn't sell products that had high CBD with the THC. That's sad. But number two is that the cannabis pharmacy was able to recommend a legitimate place to get the CBD at. So that was a good thing to be able to do that.
I wouldn't trust the Maverick.
Yeah, well, I think you have a good reason to say that. Yeah. Okay, let's see. I haven't had a patient who thought I was going to cure everything about them, and I also tell patients that, medical cannabis is treating symptoms. It doesn't cure anything, and frankly, a lot of the drugs that we use for patients are treating symptoms. So be aware of that, and if they have a condition that's part of this thing, if they have seizure disorder, they should be under, getting care for that. If they have, diabetes, they got to make sure they're getting care for that. So we're just going to help with these symptoms. As I already mentioned, the start low, go slow. And Rich mentioned the Cannabis Research Review Board already, so I leave it at that. So I went really fast, so I apologize for that. I wanted to make sure I covered all the different things. That was my last slide. So are there other questions that you might have for me? Yeah.
What about firearms?
No rules that I'm aware of regarding cannabis and firearms, using them or not using them, kind of thing. I think the same thing can be true of alcohol. I mean, I'm not aware of rules that say you can't have alcohol or buy alcohol at the liquor store if you have a firearm. So I'm not rid of any rules regarding firearms and cannabis. Are you aware of that?
Yeah, that is that it is still under federal law an illegal drug. And in order to purchase a firearm from a registered store that sells guns, you do have to sign a statement that states that you don't consume federally illegal products, or I forget the exact wording, but federally illegal drugs. So there is a conflict between the state law and the federal law in relation to, in that respect. So I think that's important to inform people about, and it relates to the purchase of that firearm from a registered dealer of firearms.
Along that same line, if someone travels out of the country and comes back in and they have it, that's a federal coming through TSA, right?
Right.
So,
Or crossing state lines.
Even, yeah, but I mean, no one's checking state lines, but
Sure.
people are actually checking baggage when you're coming in from out of the country. So that
Right.
that is potentially an issue.
They're
Under
actually,
federal law,
Under
absolutely.
federal law, I mean, if they, okay.
and there have been people checking state lines. Before we had the law in Utah, there were people getting caught leaving Colorado or leaving Nevada, coming back into Utah.
Certain areas, but I mean just casual travel.
Yeah, yeah.
Can you, is it like a prescription? If you had your card, can you go to another state with it?
Every state has different laws. Utah's a recent law. You might talk about there for other out-of-state cards.
Right. So we do issue what were called non-resident medical cannabis cards to people for 21-day periods when they visit Utah. If they do have a card that's issued by another state that is a medical cannabis card, there's a way for them to fill out an application online and to get the card and to have it emailed to them and to receive that prior to when they arrive here in Utah.
But no guarantee.
People who move here?
21.
Well, if you moved here, you become a resident, you're living here, and so you just apply for a regular medical cannabis card. Yeah, I think that there's a period of like 45 days related to the resident card. So, yeah.
And no assurance that Utah cards are good anywhere else. So we can't promise that
Yeah,
other
but
states
many
will have.
states do accept them. Yeah, I mean, especially, like, we're surrounded by states that are adult use. Nevada, Colorado, California, New Mexico, all those are adult use states. So you wouldn't have to have a medical cannabis card there, you just prove you're over a certain age.
I use the controlled substance database at least every week, and I have never seen that little marijuana leaf on it. Is that new? And I've had trouble looking at compounded substances, often testosterone, and I can see that they have some sort of marijuana card, but I can't tell what they're getting. Is it obvious how that's done to find the dosing that they're getting? Or?
There's an example in the presentation that I did. If you pull down those slides after this session today, there's an example of what it looks like literally on that slide.
Yeah, you
And
showed
so-
the leaf, but I've never seen that.
You don't have enough patients on cannabis. I see it all the time.
Yeah, but it should appear regardless of whether or not you have patients that are card holders or not. You click on it and then you, I think, search for the patient. I think that's how it works. And then to be able to get a list of the products that they purchased, you can email our office and we will verify some things and make sure that you are who you say you are. And
Okay, so
our
that's
law
just
allows
on the
a
website.
provider who's an active provider of the patient to get that information without being a QMP. Now, if you're a QMP in the program, you can access that on your own. Now, it's not the best data. Sometimes you may have to ask the patient for more information or contact the pharmacy. As Dr. Babitz can attest, sometimes it's not the best data because it's not like your typical FDA drug data. But they have very creative names for the products. No surprise, they call them by their strain names, and the strain names sound like candy. So, anyway.
So on the little marijuana item on top, if it's written by an LNP, it still shows up.
Well, it should. I mean,
Yeah.
it's a new thing, but it should show up. Anybody with a cannabis card.
Does the
No.
Um,
It just tells me they have. I just know they have a card.
Right.
I have to go in. I have to go back to the EVS as a QMP. I can go back to the EVS and try to find out any dispensing information, but I don't get. The pharmacy does not tell me specifically what they did. I have to
yeah,
go look
you
for
have
it.
to go seek it out and find out what product they bought.
Just another comment on driving. One of the very early studies in the 80s, I was the medical director for U.S. Customs. We were the first federal agency to drug test. One of the studies we did was professional Formula race car drivers, have them smoke and run the track, and everybody did well. Then we had them run the track backwards, and it was a disaster. The message was you can do what you're used to doing quite well, but when you get something new, you fail. Most drunk drivers will tell you they're doing fine. So having the driver decide if they can drive safely is pretty shaky.
Well, I'm glad that if you drive erratic, you can be pulled over. If you drive erratic and you have cannabis.
Go around backwards, I don't know.
Have you heard anything about the federal actually making it legal?
Well, the feds talk about it, but nothing's happening. And I,
Didn't they change it in 2020, and then when the pandemic hit, they put it aside?
Well, the barrier has been the Republican Senate. The U.S. House of Representatives has passed several bills. It just hasn't gotten through the Republican Senate. That's been the barrier. But there have been bills related to research. The most comprehensive cannabis research bill passed during the past year. Although it didn't do a lot, it passed, and so it was more comprehensive than other bills that have passed. It eliminated some barriers for research to make it easier for research to happen, but some barriers still exist for research that are significant, and it's like a lot of issues right now that are going before the Congress, that they're having trouble getting through one house or the other, right?
It's really emotional and political. I mean, just how many thousand people are dying from fentanyl every day? If they just made it legal, these are all accidental overdoses. Those would be over. People would be purchasing fentanyl from pharmacies, or whatever, if it was a legal drug. It wouldn't be all those accidental overdoses.
I mean, there's still, yes, not surprising, there's still a significant part of our population that considers marijuana, one of these illegal drugs, one of these horrible things like heroin addicts use and stuff like that. And so that's still in the common lay public. So.
One of the challenges, though, federal employees, from what I understand, or people who have a CDL, DOT drivers, they have to be drug tested,
Right.
and they can't even use over-the-counter CBD. No. And whereas state employees, people in private industry.
Don't go to Russia. That basketball player, that was CBD. She didn't even have THC.
Yeah.
I have a question about, so the 70,000 folks who have Utah medical cannabis cards, have we mined that data at all? As, for example, demographic data, what are the ages?
Yeah.
What are the different diagnoses?
Yeah.
Do we have some charts, like bar graphs or
We do.
pie charts?
Those are on our website.
They're on your website.
And you
too.
can sign up for a monthly update from our office where we report that information each month. It's updated.
So we can see who the most frequent.
And it's by geographic, it's by demographic.
Nice.
Uh-huh.
Thanks.
What's the affordability? I mean, what's the pay on?
It's expensive. The pharmacists have told me that for a patient who's first starting out, trying different products, they can spend $150 to $250 easily in the first month. But once they find a product that works for them, they're usually in the $100, $150 a month range. So it's expensive for people, especially people who have limited income, and it's not covered by the insurance, obviously. They have to pay for it out of pocket. So that's what I've been told by the pharmacists. It turns out if you're different than that, the same.
Yeah.
Do you know how the cost compares, like if they were to buy it in Nevada,
It's cheaper in Nevada.
It's cheaper in Nevada.
Oh, yeah.
And it's way cheaper on the street.
Right. Yeah. So there's still those options to buy it illegally in Utah, of course, and you can get it in Nevada. While you're there, it's legal, but when you cross the border, it's not legal. So that's a risk they take when they go there.
Don't get caught with the drug. You can have it in your system.
Yeah. Don't have it in your pocket. Yeah.
100% CBD costs me $50 a month.
I'd heard that. 100% CBD was costing $50 a month for using CBD products. So interesting. Okay, I think we're done out of time, and I think if you have any questions, come talk to us. But I think if you're doing the exam, I guess she has. Are you passing out an exam?
Yes, don't forget to grab that if you want to be able to
Get the credit for the
get the
time.
credit for it.
You don't need to take the exam for the CME though.
No. It's just if you want to apply these 2 hours toward that 4 hours for being a Q.